Hello, greetings from actually PEI. I'm an hour ahead of you, so I'm all fresh. So thanks, Pablo. My first meeting that I've traveled in 20 months. Glad to be traveling. So greetings from the East Coast of Canada. If you haven't been to PEI, an amazing island that I suggest that you keep that in your future travels when we're able to travel. So without further ado, thank you, Pablo, for inviting. I think this is a great educational effort in reducing the burden of hip dysplasia globally. So DDH screening can sort of range from no screening to, as we're talking about, universal ultrasound screening or clinical screening, which we expect everyone around the world to do, or to high-risk screening. So if you look at what's being done, there's a lot of discussion around how to screen and what to screen, starting from this pediatrics publication of clinical practice guideline to number of papers that are published over the years, including some randomized controlled trials that talk about what kind of screening is required. And as you can see here, some of these are fairly large, and they talk about a very low rate of late diagnosed DDH, irrespective of what kind of screening method that you end up using. And then there is this Cochrane review that's published, and this amazing paper that's done from Boston that really looked at decision analysis. The conclusion from all of these at that point in time is that there is no rule, especially when resources are strapped, for us to be thinking about a universal ultrasound screening, but definitely it warrants high-risk screening. And then we were fortunate that American Academy of Orthopedic Surgeons decided to spend a lot of money and 3 meetings, assembled 25 people from different societies together to come up with a guideline. But what came out was more than a guideline, actually, all the gaps in knowledge that were there in actually our understanding of DDH and its screening and what treatment is required, even for early management of DDH. And what's really important is this focus, especially popularized by IHDI, and thanks to Chad and his efforts, really bringing swaddling as a risk factor and bringing attention to the world that you need to pay attention to swaddling. And so in the end, the key messages are, what are the different risk factors now that now hold the test of time? Is family history of DDH, breech presentation. This next point is really important. It's history of instability. So if you're referred by a GP or a pediatrician or a primary care provider, even if they say it's a click, because often they cannot distinguish between a click and a clunk, that is a history of instability. And that is an important enough risk factor to keep in mind on swaddling. And universal ultrasound, even though we've heard several arguments why that's important, still remains controversial, as we have many other health priorities in systems like ours in Canada, where healthcare is universal, for us to actually have every single child screened, and it's a false positivity rate, which I'll come to that in a minute. And now what is really confusing is the spectrum of DDH that we talk about when people talk about incidence of DDH. This amazing paper by Randy Loader really draws attention to that. And if you take a look at this, how people have talked about incidence of DDH, you distinguish this into 3 different eras, where it was arbitrarily estimated, or was estimated by physical exam, or more recently, we estimated by ultrasound. Where we don't break it down is when that ultrasound is done. And if you look at this, and go on to look at what is the difference in terms of incidence, it's all over the map between different countries. It seems like in India, incidence is low because people carry them on the side. It's because they're not diagnosed till very late, and they're not diagnosed for a long time. And if you look at this paper from UK that talks about prevalence of dislocation of DDH in Britain over the past 1,000 years, very provocative title. And you look at that, they clearly talk about the incidence being different from when that ultrasound is done and when you diagnose. So obviously those that have universal ultrasound screening, and if they're screening within the first 2 weeks, they'll find a higher incidence of DDH versus someone that's screening them at 6 or 8 weeks of age. And the other important, I think, contribution for us to be thinking about between IHDR and IHDI is the spectrum, DDH severity spectrum. So you can have from mild dysplasia to dislocated reducible hip. And each one of them is a different beast by itself, and it requires a different strategy in terms of its treatment. And our literature is filled with people talking about DDH in very different degrees of severity of spectrum. But it's also important to understand the regional differences in when they're actually diagnosed. In our original IHDI study that involved only countries from the West, our mean age of diagnosis was around 3 or 4 years of age. 3 or 4 months of age. And when we added countries like India and China, the mean age there is very different. And so you can see here, the mean age is about 4 months in the West, and India, it's about 31 months. So quite different. And those of us that are here talking about solving a global problem, we really need to think about our combined population of the speakers here that are representing the countries versus the countries that are not represented. It's a huge issue where we really have to think about how can we be more relevant to the 90% of the world we don't live and practice in, where the burden of dysplasia is probably 10 times greater than what we find here. And this classification developed by IHDI could be quite useful in places where there are no ultrasound, but this requires to be validated against an ultrasound. And we're working with our friends in Europe on trying to do that. And we're also working on developing care pathways for country specific, because some of their geographic needs and their systems are very different. This effort with India, we brought together 7 large societies with a combined membership of 120,000 medical people. And they've come up with their first care pathway in India for DDH, and that's just the starting step. And as we have heard, and I know Pablo uses this quite a bit, I think these could be some of the future directions where people say they don't have access to ultrasound. With artificial intelligence and with processing, we might be able to help them with that. And this network that we're trying to bring together, all of the different pediatric hip conditions together, as you can see here, very many different hip conditions that we have, and bringing all of the hip experts to collaborate could be the way to go to really address some of these global issues. Thank you.